Thank you, Nico.
Thank you very much for these kind words. Almost too kind, I would say. No. I'm very impressed that I've been invited to this De Lange Symposium, and I thought the topics are very interesting. And I think it's a very serious symposium, although I was a bit surprised when opening the app, and maybe you all saw it, when you opened your app in the App Store, it says the Lange Symposium is categorized under amusement. So, which is also true. But I have not too many jokes, actually. But so my topic is resynchronization. Is it worth the long term? And I think, is it a yes or a no? I think adults with normal anatomy, it's a yes with loads of evidence. In children with normal anatomy, I think it's a yes square, but to be honest, without much evidence. And I think in adults and children with congenital heart disease, it's also a yes, also with not so much evidence. So what are the indications for CRT in children and congenital heart disease patients? It's the usual one, the systemic LV failure with left bundle branch block or RV paced patients. It's the systemic RV failure which has a right bundle branch block or is LV paced. It can be a single ventricle patient with any type of block or with single side pacing, or it can even be a pulmonary RV failure with a right bundle branch block. And these last 3 points are specific for congenital heart disease. So if you look at components of cardiac output, it is, you need heart rate, you need contractility, you need preload, you need afterload, and you need synchrony, or synchronicity, as this Police album from the, I don't know, the 70s or something. If you look at the classical left ventricular desynchrony pattern, this is a strain rate image. You have this early, go back. You have this early septal contraction and the early lateral wall stretching, and then you have the peak septal contraction, which is followed by a rebound stretching, and you have a lateral wall contraction even after aortic valve closure. So it looks more or less like this. So you have a contraction of the septum with a pre-stretch of the lateral wall, and then the other way around, contraction of the lateral wall and rebound stretch. So that is the clustered dysynchrony, which is actually very amenable for CRT. You can also have dispersed dysynchrony, where it's sort of scattered, and that's typical sometimes in cardiomyopathies, and they are not very good for resynchronization. So also in children, you can have excellent results from CRT, as you can see here on the left side picture. CRT in a dilated cardiomyopathy with the ejection fraction 14% and 28% after 3 weeks of CRT. But you have to choose the right indication. But you can also see in this same patient that you have this here, you have this classical dysynchrony pattern with the early contraction, the pre-stretch, and the late contraction and the rebound stretch on the lateral wall and the septum. So this patient is a good candidate for CRT. And as you can see, after synchronization, you see a very synchronous contraction of all segments. So the evidence in adults is overwhelming, I would say. So you have the MADE trial on the right side, where more than 1,000 patients received CRT ICD, and 700 plus patients received ICD only. And if you look at heart failure-free survival, then you can see the difference. CRT makes the difference here. If you sub-analyze this group, this MADE group, as you can see on the left side, then you can see that those that have good results of the CRT are the left bundle branch block patients with either QRS duration over 150 milliseconds. They're doing the best, they have the best results, or less than 150 have slightly less better results. But if you look at the other group, sorry, the non-left bundle branch group, they are not so good actually. So in general, it's just not any prolonged QRS, but a specific electrical activation delay within the systemic ventricle is the indication for CRT. Another data from the adults from the MADE trial that CRT really is a good therapy long-term as well. In this paper from Jack, also an analysis of this MADE trial patients, you can see that, you can see that 40% of this group has complete reverse remodeling of both the left atrium and the left ventricle. And if you look at this graph here, probability of heart failure or death is very good in this patient cohort. If you look at those who have only part of the reverse remodeling, either by the left atrium or the left ventricle, they are doing less well. And if you have lesser reverse remodeling, your results are less good. So in general, there's a large group that has reverse remodeling in 40% with good long-term results. What about pediatric data? Those are the 3 studies where we all base it, our evidence is based upon. It's a multi-center from the US, it's a multi-center study from Europe. So is this one from Jubin and from Januszek, and then the single center from Boston. And if you look at this retrospective data cohorts, you look at improvement of ejection fraction, then you can see that in the single center study of Chechen, the ejection fraction improvement was not so much, 5 or 6%. In the multi-center study, it was better, and from Europe, and in Jubin's study as well. But you have to be honest, these data are, the question is how reliable these data are, because sometimes they are just from many centers with spreadsheets filled in how the ejection fraction improves, so you have to be careful. If you look at the type of electrical dyssynchrony in this group of patients, again these 3 studies, you can see that in blue that the majority of these patients are actually paced single site. So that the main indication of CRT in this pediatric cohort and congenital heart disease cohort are conventionally paced patients. And if you look at the Januszek, the Europe data, only a small group has left bundle branch block, non-specific bundle branch, right bundle branch block in green, and in purple it's non-specific. So this means that we could avoid CRT in most children and congenital heart disease patients by avoiding iatrogenic dyssynchrony by conventional pacing. And I think this is where the easy money is in our patient cohort. So what we know about this iatrogenic or pacing-induced dyssynchrony in pediatric patients, I think the first studies on detrimental effects of pacing are pediatric cohorts, which is interesting, not adult cohort, but pediatric cohort. We know that about 6 to 13% developed LV failure after chronic RV pacing. Those are particularly these infants with the congenital AV block, the immune-mediated AV block. We know that if you have left ventricular, systemic left ventricular failure, CRT almost results in complete remodeling in many patients, so it's a very effective therapy. What we know is that the optimal pacing sites in children are the left ventricular apex and the left ventricular lateral wall. And what we also know, and I think that's the most important passage of today, that the RV free wall pacing is really, really very bad. If you look at, this is a case of RV free wall pacing with a very much delay in the septum and the posterior wall. And if you look at this graph of this study from, again, from multi-center study from Europe, from Jan Januszek, where you can see that RV free wall, RVOT and RV lateral wall have a very, is the worst group with a low ejection fraction. And if you look at the left lateral wall, left ventricular apex, and base even, have better ejection fraction. And I think it's very easy if you have an infant which requires pacing, which you opt usually for epicardial pacing, it's so easy to put your epicardial leads on the left ventricular apex, as you can see here. So I think that's very important because thus far the long-term outcome of left ventricular apical base pacing is quite good. What about the systemic RV in the single ventricle? I think that's more complex than just dyssynchrony because you have intrinsic myocardial dysfunction, you have AV valve regurgitation, Fontan physiology, which complicates the situation. So I think you cannot expect full recovery and full reverse remodeling. And the data on the efficacy of CRT in systemic RV is quite conflicting. Like the Boston group has poor results, the European study shows quite good results. So we are not there yet. And I think with the univentricular patients, it's even more complex because there are hardly any data or very few data. What we do know from this European study is that if your left ventricle has to be resynchronized, that has the best outcome. So what we know, it was already addressed by Dr. Brizard this morning, in the congenital corrected transposition patient, almost 30% developed somewhere an AV block, either surgical or spontaneously. So it's a group that requires pacing in 1/3 of the patient population. We know that especially in this group, pacing is not good. You have the septal shift and secondary dilatation of the systemic RV and annulus with tricuspid regurg. Some studies showed good results of CRT, like the data from Prague, that they have good results of CRT, but others don't. And what is sure is that tricuspid regurg does not improve after resynchronization. But this data, actually not quite recent data, are quite worrisome. If you look at patients with CCTGA, conventional repair, not anatomic repair, conventional repair or not repaired but require pacing, you see the outcome, which is the outcome is RV function decrease of deterioration. Here's the criteria of the definition of what they call mild, moderate, and severe RV function based on the RV fractional area of change, and RV dilatation, RV end diastolic area. But what you can see in the paced group is that they're doing very poorly. So they have a continuous decrease in their RV function. And what is even more worrisome, and I think that addresses also the point, let me go back. So can we resynchronize these patients? Yes, we can do it transvenously, like we do here. This is a coronary sinus angiogram in a 12-year-old girl, already conventionally paced, and the CRT, the coronary sinus lead, was placed here. And this child actually has a 13-year follow-up and has actually improved after CRT. But if you do transvenous CRT in CCTGA, you have to be aware that the coronary sinus anatomy in the cardiac veins can be very abnormal. Sometimes you have an atretic coronary sinus ostium, so that can be quite difficult. Here you can see a good result of in an 18-year-old boy presenting with heart failure who had a sinus inversus CCTGA PS conventional repair, was quite okay, had a QRS of 160 milliseconds, but at the age of 18, he rapidly deteriorated with tricuspid regurg and actually had quite good improvement of CRT. So I think some of these patients actually respond quite well. But if you look at, and that addresses the topic of Dr. Brizard this morning, this is a CCTGA group. Also after anatomic repair, 33 patients of the 42 had anatomic repair, so the double switch or the Rostelli mustard operation. And if you look at this patient cohort, if they are univentricular paced, they're also doing very bad. Freedom from systemic ventricular dysfunction, which goes, this is follow-up in years, that they deteriorate. And if you upgrade them in this series, if they are upgraded to CRT, they don't improve. So, and that is the reason I think Dr. Brizard already said that they actually have to consider in this group of patients to immediately start CRT, even after anatomic repair, to prevent deterioration of your right ventricular function, of your left and right ventricular function, even after anatomic repair. Then the last, one of the last topics before going to the follows, the ventricle in pacing in single ventricle patients, which is also, I think, a very bad combination. Again, a series from the US, recent, where they did control group of 53 patients, 22 patients were paced, So these are patients after Fontan, and if you look at the results, the group that is paced has a high percentage, 70% almost, of ventricular dysfunction, AV valve regurgitation, heart failure medication, and transplantation, as compared to much better results in the control group that is not paced. So pacing, single-site pacing, is also very bad in Fontan patients. The Boston group has tried to solve that problem to be quite aggressive with CRT in this group, and they advocate to place the leads as far as possible in the anterior posterior position, as the maximal distance you can reach between the two ventricles, sometimes even lead a lateral thoracotomy for that. And this was their short-term results of CRT, with improvement of ejection fraction after biventricular pacing. But the Boston group recently also showed their data on long-term results of CRT, the long-term results, and they're not so good actually. So they do primary CRT in these patients now, before as a primary therapy. But that group actually is not doing much better than the single-site ventricular pacing. So also in the Fontan group, we are not yet there with a solution for how to pace these patients. Then the most controversial topic, I think, or the more experimental topic, is patients, the follow patients, it's the largest group, to do pulmonary RV CRT. Right bundle branch block is the most frequent dysynchrony pattern in congenital heart disease. So you know all the fellows with the right bundle branch block. We also know that it's a chronic RV failure model with the right ventricular volume overload due to PR. And we also know that some of these patients, if they have too dilated RVs, ejection fraction is too low, that they don't recover, or QRS is more than 160 milliseconds, that they don't recover from after pulmonary valve replacement. So PRV alone may not lead to normalization. Is this due to myocardial fibrosis, or does this dysynchrony play a role? And actually this is very interesting work from Prague again with the Maastricht group. But I have some serious remark about that also. This is their first case of a right bundle branch block patient with a QRS of 200 milliseconds that did not improve after pulmonary valve replacement. And this is the strain pattern, which shows sort of identical RV dysynchrony compared to the LV, with the pre-stretch, the rebound stretch, and the late contraction. So it looks like the classical. And what they did is, and they've now done it in about 6 patients, do fusion pacing. So they do RV pacing on the lateral, the latest activated area in the RV. So you get this sort of ECGs, fusion pacing. So they try to tritate the PR interval of the AV interval, that you have as much as possible fusion pacing. And what they've seen in this group, they have now presented 6 cases. 3 of them had additional surgery, so keep in mind that there's also a bias there, but those 3 are patients that only received CRT, and they all improved regarding QRS duration, NIA class, New York Heart Association class, and NT-proBNP went down. But it was also already mentioned by Dr. Übing this morning that we have a lot of data in Leiden on RV activation maps in this follow the VT mapping protocol. And what we very often see is quite a healthy RV with rapid conduction in large parts of the RV with only small area of slow conducting. So I'm not sure if, I think it is good for some patients, but I think you have to be very careful what you do. So this is to conclude, resynchronization in children with congenital heart disease, is it worth the long term? Well, I would say yes, of course. I think it's a strong tool to treat heart failure in both children and congenital heart disease, especially in patients with systemic LV. The low-hanging fruit, I think, is prevention of iatrogenic dysynchrony by optimal single-site pacing in young infants, which is the LV apex, is the most easy part to reach if you do it epicardially. The principles are quite similar to adult patients, but of course, as you know, we have very structural heterogeneity, and in small kids, it sometimes needs a different approach. The long-term outcome of systemic RV and single ventricle is, I think, yet unclear. And what we should do, I think, in this cohort of patients, do very detailed, gather all the information you have regarding electrical and mechanical dyssynchrony, doing your electroanatomical mapping before you place your CRT, do extensive echo studies or MRI studies. And the other one is the pulmonary RV synchronization. I think it's very interesting, but it's still very experimental. Thank you very much for your attention.